Good morning and good afternoon, everyone, and welcome to the National Center on Substance Abuse and Child Welfare's Dialogue with Experts series, Data-Driven Decision-Making, Implementing Evidence-Based Practices for Families Affected by Substance Use Disorders and Child Maltreatment. Today's webinar is presented by the National Center on Substance Abuse and Child Welfare. My name is Somé Lewis, Program Associate for the National Center. We want to express our gratitude to everyone today joining us. We really appreciate your time. This presentation was developed by the National Center on Substance Abuse and Child Welfare, which is an initiative of the Department of Health and Human Services, jointly funded by the Substance Abuse and Mental Health Services Administration Center for Substance Abuse Treatment and the Administration on Children, Youth and Families Children's Bureau's Office on Child Abuse and Neglect. We thank them today for this opportunity. And with that, I'm going to pass it off to Dr. Nancy Young. Thanks, everyone.
Great. Thank you so much, Somé. We appreciate everyone being here, as Somé said, and we appreciate Dr. Brooke sharing her expertise with us. We know how important data are to being able to understand the needs of families, to be able to put together the plans that families need, but importantly, the demonstration of outcomes to know what works. And that component of understanding as we go along, what does quality mean? How do we have a quality improvement approach to services and innovations that are being put in place? And then obviously the importance of sustainability and how do we determine what works and how do we make that available for the breadth of the populations of families across our country in all of our communities that need specialized services for parents with substance use disorders and they're in the child welfare system with child maltreatment. The data are important for lots of reasons, and if we go to the next slide, this is one that we track. We've been tracking it for a very long time. These data are from the data set called AFCARS that gets submitted from the states to the federal government. And most of you are familiar that there are a couple items that indicate if there are alcohol or drug abuse by parents, or children are actually in the data set also, that are identified as a condition of removal. So when you look at the data across time and you say, oh my gosh, we're up to 52% of infants, critically important. But we know, if we can look at the next slide, that even though it's over half, when you look by state at those data items, the red bar are the older children, the white bar are under 1. You see that in almost every state, the prevalence that's reported by child welfare workers in the data set is much higher for infants than for older children. But when you look at that overall prevalence and you say, oh, it's half of the under 1 population, we know it's a lot more than half because many states don't report or they have very low reporting of parental alcohol and drug as a factor in the case when the child is removed. So we actually have these charts on our wall in our conference room and think that it's pretty important for everyone to be continuing to monitor what's going on in your community and in your state about understanding this population as a way to set the groundwork for some of the things that Dr. Brooke has demonstrated over her career. Next slide, we'll talk about Dr. Brooke. We were reminiscing yesterday that I think we know each other something like 20 years. But when we were creating these expert series of bringing in guest speakers to share their knowledge, when I think about experts in research in this topic area of substance use disorders and child maltreatment, Jody Brooke is the one who comes to mind, certainly at the top of my list. Her research career has focused on this population and importantly, really finding out what works and how to improve our services to improve the outcomes for children and their family. Jody has a LCSW and a PhD in social welfare. She's been a leader in many federal initiatives that are related to this population. The evaluator in 16 federal grants. But importantly, for those of you who are familiar with the regional partnership grants, there have been 109 regional partnership grants across a little more than a decade. And Jody has been the evaluator in 6 of those across 3 different states. So she brings such a wealth of experience to this topic. And we're just delighted, Jody, that you can share with us today your knowledge. And I'm going to turn things over to you, Dr. Brooke.
Thank you, Nancy. I appreciate the acknowledgement of my work. I will tell you, it has been a labor of love. I have been committed to this population really since I was working in clinical practice in women's substance abuse treatment. Since I started my PhD and then subsequently in my career at KU as a researcher and teacher, my work has really centered around regional partnership grants, systemic interventions to address the relationship and the intersection between parental substance abuse and child maltreatment. And through that work, I've really looked at different factors that I think are important, such as implementation frameworks, which I think are critical. But I've also looked at the innovation of family drug courts, which has just expanded tremendously in the time that I have been researching in the area. And then I've also, through my work in 3 different states, I have had the fortunate opportunity to evaluate 4 different evidence-informed interventions. And those are strengthening families, celebrating families, attachment and biobehavioral catch-up, and solution-focused brief therapy. Today, what we want to talk about and what we want to focus on is the importance of quality data and how this really should be a part of informing your thinking from the time you are conceptualizing your program to the final evaluation of your program. Evaluation is not something that should happen in a removed way. It's something that should be on the ground and in partnership with those who are implementing at all of the sites. So we're going to talk about selection, implementation, pre-implementation, evaluation, and then if we have time today, we'll take questions, and if not, we'll be happy to address questions at our follow-up meeting on Thursday. So really what I hope to share with you all is lessons from the field. And these are important, and you'll hear me share stories throughout today's presentation. And those really are about my experience as an evaluator in this area. And I really think that the importance of this is highlighted through the selection and the implementation and the evaluation of these evidence-based interventions. Right now, we are at a time in the development of our field where the use of an intervention that is evidence-based is really driving what practices are occurring to some extent. And it's more important than ever that we determine what works for whom and under what conditions. And so as this quote displays, really big data are the starting point in your thinking. They're not what happens at the end. They're really should be there all along. And so the first thing I'd like for you all to think about is the selection of an intervention and the selection of who you're going to work with. The problems in this particular population, substance abuse and child welfare, there are a myriad ways in which you could slice the pie to begin to look at how you're going to make a difference in the lives of these families. And so we're going to talk just a little bit about how you use data to look at your target population, your intervention choice, kind of those geographic areas, and the service and demonstration sites. So that target population is the who that you're looking at. Who is at most risk for experiencing the problem that you identify. And it's not just who they are, but to the extent that you're able, what do these families look like? What are their characteristics in the child welfare system? What needs do they have that are that you have adequate resources to address? And where do you have gaping holes? And this target population identification should happen through an analysis of data. And so there are numerous ways to do this. I have found that when you put together different perspectives on looking at a problem, generally you get a more robust understanding. So it might be that we look at administrative data and we run data from the AFCAR system or the state's current active child welfare system. Could also be that you do case record reviews. Before one project that we initiated here in Kansas, me and another colleague collected about 45 case records from different areas that met certain qualities. And we really dug in, and then we spoke with the workers who worked on those cases. And then also looking at local reports and local information, especially if you are planning to implement statewide or in multiple locations, those really should be treated as separate, and you should look at each one because each implementation is going to have its own strengths and challenges. And so you also really should look at data to confirm that target population's needs. In terms of choosing your intervention, the evidence on the effectiveness of an intervention for your population will really help you choose what to implement, but that doesn't necessarily tell you how to implement that program successfully. And so you need to move a little beyond just the choice of an intervention, which is really important, but also the implications of choosing that intervention. So for example, how usable is the intervention? How quickly can you take an intervention and do what I call plug and play? What is the training like? What is the support from the provider or whomever is purveying the intervention? How usable is it? How cost effective is it? You have to think about your the long-term needs of the population, and the fact that you might have a grant gives you 5 years or however long you're funded for to implement with some support from the federal government or whoever your funding source is. But ultimately, if that project is not cost effective, it's not going to be sustainable. How compatible and adaptable is the project to the population that you're serving? Because your population's needs are what they are today, and you will also learn more about your population over time. And as you do that, is the intervention able to be nimble and to work with you in adapting? And my final point here is about the complexity of the intervention. And this is really just kind of a lesson from the field that I know that in Kansas, we have implemented interventions. And then this was not through the regional partnership grant, but in another initiative where long-term, what we really learned was that the training and the sustainability requirements for the intervention were not doable for our public child welfare system and its privatized providers. We heard information over and over again about it just takes us too long to train trainers. It takes us their fidelity monitoring for 18 months after training was really too intensive for us, and we couldn't sustain this after the grant funding went away and the intervention was very complex. And so because of that, ultimately that initiative failed and we had to go on and choose a different evidence-based intervention. So that choice is really important. And looking at your geographic areas and selecting your demonstration sites is another way to really use data to examine that target population and the geographical areas and their needs, because you're not just going to have a target population and an intervention, you're probably also going to have multiple sites of the intervention. And so you have to use data at every stopping point along the way. So this project example number 1 is from a Kansas Regional Partnership grant funded in round 2. And one of our first points of action in our pre-selection phase and before we wrote the grant was we went into the state's child welfare data set, and then we were able to run analyses and take a look at how children removed for reasons associated with parental substance abuse, how were they represented proportionally among the population of kids in the child welfare system. And then we conducted a survival analysis to analyze the reunification rates when we compared those kids to their counterparts. And that way we felt like we were doing a really good and robust job at saying, this is the need of, here is the problem, and here's how we're substantiating the need for the intervention that we're about to propose. And so that was a really important part of our work. And then what we also learned here, and I think this is a really important piece as well, we originally, in the first round of the regional partnership grants, implemented an intervention for children ages 4 to 17 in the child welfare system. We didn't have a lot of data back then, so this was around 2007, and the state just didn't have a lot of data about these kids. But over the next 5 years, the data became more populated and robust. And what we learned is that we had spent 5 years implementing an intervention for kids ages 4 to 17. But if you look at this figure right here, what you see is that ages 0 to 3 were indeed our biggest problem. So, so we implemented an intervention, but we didn't target the population that had the highest need. And so we were then able to go back and write again for another grant to help implement an intervention for this younger age group. And we ended up going with a modified version of the same intervention just so that we would have stability in the intervention. But the point of this is that had we had the data and been able to analyze it better, we would have chosen a different intervention right off the bat, because we would have known that our biggest population of need was ages 0 to 3. So in looking at our selection of demonstration sites, so this is an actual map that we used in looking at the needs across the state of Kansas. So this is a county level data map that shows the number of children in out-of-home placement due to parental substance abuse by our state child welfare catchment areas and the last 6 months of AFCAR's data at the time that we did this. And we put a 45-mile radius around it. And what we then specifically drilled down to look at how many kids in each area were there to help us determine our site. So it was the actual number of children who were in out-of-home placement, which substantiated the level of risk that we wanted to be able to display and talk about when we were making a selection in the state about which sites we were going to go with. This was also important because we were randomizing in this implementation. And so, like, for example, this figure over here of 8, well, we knew that if there had only been 8 kids in this county for the past 6 months, and we were randomizing on a 1-to-1 ratio, that would be only 4 families in the group. And that was not enough at the time, or it just met the threshold for the fidelity of the intervention. So having actual numbers like this and drilling down is not just important in substantiating your need, but it's also important in your site selection. And what we ended up doing here with this county that had 8 is we offered the intervention every other cycle. And so that way they could build up larger numbers between times that the intervention was offered. So, so there are really valuable and practical lessons that can come from really drilling down your data to multiple levels within the area that you're planning to serve. And, you know, we also were able to identify key considerations, and these considerations could vary really widely among sites. And, you know, in some areas of Kansas, we have substance abuse treatment resources available, and we have ample foster care placements available. There are other areas of Kansas where you have to drive 3 hours for a substance abuse treatment center, and where children are going to be placed 2 to 3 hours maybe away from their parents, thus making a school evening intervention really challenging to implement. So they're just key considerations. Anytime you're looking at the data are going to give you more information about this population. So, you know, we often learn things about parents' access to substance use treatment, the need for adolescent treatment, and an increase in the numbers of infants prenatally exposed. We've actually seen that by running data analyses over time. We can watch certain indicators go up and down, just like the National Center is doing with looking at the overall population. So pre-implementation, what are our factors to consider? An important one is to think about the required sample size. And this is really important because in the end, you need to have enough data and to serve enough families to be able to run an analysis of effectiveness that is methodologically sound. And so for us, we were able to conduct power analyses that said, like, this is our target. We need to have at least 350 treatment group families over this period of time in order to run our analyses in time to be able to develop a sustainability plan. And so we were then able to establish metrics for each cycle of implementation that told us if we were doing well or not, or meeting our threshold or not in terms of achieving a required sample size. The next is fidelity data, and we collected fidelity data on numerous projects that I'm talking about here. And those fidelity data were measuring really how faithful we were being to the curriculum of the intervention, but they also were measuring other things, which I'll go into in just a moment. So we use data to conduct trial runs and usability testing on our measures, and this was incredibly helpful to us as well. So I think you can see a pattern emerging here, which is that the program evaluator or the evaluation team, because it usually takes more than one person to do this, was really present every single step of the way with the site. And so there is no like removed evaluator who gets the data at the end in a pretty little clean data set that they then tell you what your outcomes are. If that's the evaluation model that you're using, you're not using evaluation to its fullest, because it can be really helpful at so many points along the way. So earlier I spoke about sample size and the need to do power calculations to tell you what the number is that you need to achieve. But we also set up fidelity testing, and that is, how will we collect those data? Who will collect those data? How will we get the feedback loop back to the community and to the site? And then how will we use those data to influence our implementation of the program? And we did that basically through using trial runs and establishing multiple feedback loops that allowed us to gather qualitative data and some quantitative data, which I have a slide I'll show you during intervention trainings and the initial rollout. And then, we also, in terms of usability testing, we tested all of the data that we were collecting, but we also were trying to get a barometer from the sites about the evidence-based practice attitudes and challenges and anticipatory feelings and thoughts that people who were on the ground were experiencing as we were implementing these projects. So in a separate project that I had, we conducted a study on driving organizational and systems change by examining like child welfare supervisor and administrator perspectives of initial implementation. We wanted a really clear understanding of implementation, like from the ground level, because initially we were having low completion rates and intervention completion rates for one intervention that we had. And so we conducted a qualitative study and said, like, from your perspective here, not just supervisor and administrator, but implementing worker, we want to know why aren't folks finishing this evidence-based practice? Like, it was a 14-week intervention and most families weren't making it past 9. And so we needed to learn the nuances and the dynamics of what was happening through that, the implementation of that, in order to find out if this was something that we needed to change, to modify, to choose a different EBP altogether. How was it we needed to deal with the fact that families weren't finishing the intervention? And so we found that the supervisors wanted ownership in the intervention selection and in the assessments and in the measurements, and our assessments and measurements were too long. And the supervisors and those on the ground really felt like they wanted to be more a part of the selection process at that point, and they wanted a voice. And so we were able to find that out by doing a qualitative study that helped us with that. So we were also in a different project working on fidelity testing and group leader session by session fidelity. And so what this slide shows you is that by cohort in each site, we were measuring in cohort 1 and in cohort 2, we were measuring along 5 domains. And the first domain was like the community or the environmental context. The second was, did we have the right implementation in place for the population characteristics and their risk level. In this, we talk about race, ethnicity, language, recruitment, the family demographics, their capacity to participate, referrals, things like that. In the program area, we look at whether critical elements of the evidence-based practice are being implemented as they are planned, the use of incentives or childcare, materials, things like that. And then for staffing, we're looking at the number of group leaders, whether the site was coordinated well, things like that. And then under curriculum, we're looking at strict adherence to the curriculum. And so on a scale of 1 to 5, we were able to rate through an implementation fidelity checklist all of these. And what this ended up really helping us with is like, for example, you can see here, site number 2 for cohort 1, they were really struggling with staffing. And site number 2 for cohort 2, they were still struggling with staffing. And so what we did here was we were able to give them some support around staffing. There was also some environmental and contextual factors that ended up being really important. And so as a result of having this information, we were able to move the intervention from the child welfare agency, which is where we were holding it initially, to a community faith-based organization where parents felt more comfortable going, where the facility was better equipped. There's a meal associated with one of the EBPs, 2 of the EBPs that I've worked with. And so like the child welfare agencies were not set up for this, and it created a really chaotic environment, and the families didn't like coming to the child welfare agency. So having this information was very critical in that it gave us the data we needed to say, okay, we're going to try something different here, and we're going to move, we're going to move the location, or we really see that the staffing is struggling here with this site. And so how can we go in and troubleshoot that? So again, I'm back to that notion of key considerations and the things that you should be thinking about. These things, if you're analyzing your data regularly, they will appear to you, but you also have to be strategic, and you have to include practitioners from all of the different stakeholder groups that your initiative is hoping to influence. And the practitioners are really critical because they provide that valuable day-to-day input that you need in order to make changes, and to just know you're doing it well. That's also a really important aspect of this. In terms of factors to consider once you're really moving into a deeper implementation of the project, you can use data to help you, with a variety of things. But as you implement, you have to set up a structure that allows you to monitor certain things. So data entry standards by the staff that's in the field, how parents are attending the programs, completion rates, fidelity adherence, and really necessary changes that need to be made. These are all really important factors. And in terms of data standards and protocol, you really have to be, I can't emphasize this enough, the consistent monitoring of data entry. So the research team that we have formed looks at data entry for every single week for every single referral into a program. And I tried spacing that out and going like every 2 weeks or monitoring data entry every month. And the problem is it gets too long and people misplace forms or they forget exactly what happened. And so if all data aren't entered within a week of the service experience, we go in and contact the person who was supposed to enter the data and let them know. And we try to then also get a quick handle on any missingness in the data and any gaps in our data collection protocol. And we also, like, as we're looking at, say, a 14-week cycle of an implementation of a program, we will know if we don't have data on somebody for 2 weeks in a row, we will know that that person is not attending, and we can then talk to the program site and say, you know, what have you done to reach out to this family, and then establish a protocol for that. And we can do that by location, by agency, and by the staff. And so it's creating an infrastructure for monitoring the operations of the program. That's what you're doing here, is you're creating an infrastructure. And when you look at fidelity, we were collecting fidelity every time clients interacted with the intervention. So in a separate intervention, which was done at a substance abuse treatment center, for example, and we were implementing solution-focused brief therapy with one group of parents and CBT with another group of parents, what we would do is we would have random pulls of implementation monitoring sessions where someone could go in and watch the session or ask the individual certain implementation questions about how the session was playing out. And then we put in formal feedback loops from all of our stakeholders to examine, like, if the implementation or the intervention needed to change and how. And we did that really by surveying every quarter, sometimes every half year, semi-annually, for those that were up and running. But we would put these feedback loops into place and create a structure around that so that we could know what was happening in the field. In this example, and this is really a pretty data-driven example, we knew that in our project, one of our projects in Kansas, that we had set up a randomization ratio of 1-to-1 for the treatment to control group. And what we learned is that we needed to go to a 2-to-1. So 2 families to the treatment group, 1 family to the control group, because we were having some sites who were having difficulty recruiting. We were also having some workers say, you know, this really bothers us that it's 1-to-1. And so we switched it to 2-to-1. Now, the back end of that is that when you go to analyze those data, you're looking at some people who are randomized on a 1-to-1 ratio and some folks who are randomized on a 2-to-1 ratio, and it can influence the findings of your study and it's a methodological error. It's basically what I'm trying to say that you have to account for. It's a methodological change that you have to account for. It's not an error because we did what we were supposed to do, but it is a change in the protocol. And so when you're analyzing your data on the back end of that, you really have to take this into account in order to have the level of rigor that you want to have in reporting your findings. So, you know, these can be painful lessons, because like that last one where we changed our randomization ratio, we didn't really even think that through. We were just being responsive to the sites. And then when we went to analyze the data, we realized, wait a minute, we really need to treat these as related but different. And so, you know, there are just always things that you have to consider. In this next project example, I'm going to give you all, I was part of a project where we implemented 2 evidence-based parenting programs in sequence. And so families experienced as part of family drug court involvement, one parenting program when they were first involved, and then another parenting program later in their involvement with the drug court. And we really had a hard time with adherence and fidelity and attendance at the later intervention. And so we wanted to know if it was the timing or was it the intervention, and what were the factors that made that intervention not work where it was. And what we learned is that the staff felt like and the families felt like that second intervention was just too long, and 28 weeks of intensive parenting classes was not in the best interest of the families. And some of the content of the second one was geared towards families that were further along in recovery than the families were who were presenting. And so we ended up modifying and dropping the second evidence-based parenting program as part of that family drug court experience, because we tried for 2.5 years to get that second parenting program to stick, and it really didn't. And so we tried everything we knew, and then we eventually dropped it, and people were then attending the first one much more robustly, and we ended up creating some graduation groups and things like that. So, you know, it wouldn't be, we wouldn't have this information unless we had established the feedback loop, and then we went in and talked to folks about what was going on. And so I encourage you all to remain connected to the field when you're implementing and rolling out and really planning for these interventions. My next example is one that I think is really interesting. We were in 2 separate states offering statewide educational trainings for folks about prenatal substance exposure and about some common challenges that families face with young children and substance abuse, and what are some of the barriers to reunification for these families. And we were planning these large statewide implementations of training, and we began surveying people. Fortunately, in the very beginning, we began surveying them about what they got out of the training, and also about their knowledge of the Child Abuse Prevention and Treatment Act reporting requirements. This was just a question we had about, do people know and understand what they're supposed to report? And what it turned out is that most people didn't know and understand their requirements under CAPTA. And these were healthcare professionals, legal professionals, child welfare professionals, early childhood development, like parents as teachers professionals, and the Head Start agency in the area, and all the early childhood providers. Everyone was welcome to attend these trainings. But what we found out is that almost universally, no one understood what their reporting requirements were. And so if we hadn't issued these surveys in the very beginning, we would never have learned this. So we went back and modified the training to include this information first and foremost. And we've gotten feedback that that was really very helpful to do. And so, you know, it's just really important to figure out what data you can gather, how you can gather it, and to create the infrastructure along multiple domains. So, you know, the data in all of your child welfare systems are really valuable to program development, program implementation, fidelity monitoring, and continuous quality improvement. And much of what we did really was about formative outcomes and looking at what's happening along the way to achieve that ultimate outcome that we wanted, which of course was, improved child well-being, improved safety, and permanence. And so we had these big picture long-term goals, but we needed to measure things along the way. And then also be able to really identify if we had an outcome that was a long-term outcome, how were we going to measure that? Was that reunification rates? Was it at faster time to permanence? Was it no more maltreatment reports within a certain period of time? And fortunately for me, because I've been working long-term in this, I've also been able to analyze reentry data, because if you think about it, child reunification is actually a very incomplete measure if the families are just being reunified and coming back into the system quickly. And so we've been able to create longitudinal databases and to follow the families that did indeed come home, reunify faster in many of these instances. But now the question is, does the reunification stick? And so we've been trying to answer some of those questions, and this takes time. It takes, at least 4 to 5 years after the reunification is what we've been following. So there's really data in child welfare systems that can help you along multiple points in time. What you have to do is set up the system in order to do that. And I think you all can probably surmise that flexibility has been a really important aspect of this work. You have to be able to look at what the data are telling you, then, follow up and kind of put your ear to the ground and find out what you think are the contextual factors around what you're seeing, and then make your changes, and then start the measurement cycle all over again. And so, you may find that this selected intervention just doesn't work for the needs of the target population, or just that you need to change it in some way. So in terms of your ultimate program evaluation, your outcomes evaluation, for us, what we've looked at is gathering and creating a data collection plan that really focuses on what are the pre-participation and post-participation differences in what we're trying to measure, whether it's family functioning or child well-being or parental substance abuse recovery status or time to reunification. What are the pre and post outcomes differences? What are those placement and stability outcomes that you're looking for? And what are the stakeholder outcomes? And that's really important because to implement these types of interventions and to work collaboratively across systems, everyone has to be able to get on the same page about what outcomes are important to them. And then you have to put the plan in place to measure that. And you may have to have a lot of conversation with different stakeholders about which outcomes are meaningful in terms of participation for them. And that's part of collaboration. It can at times be uncomfortable, but it's a necessary discomfort if we are going to improve the child welfare, substance abuse treatment, court experiences of these families. All the stakeholders have to be allowed to have a voice in the outcomes that matter. And then finally, a cost analysis. And I realize that most initiatives don't conduct cost analysis, and the field of cost analysis and cost benefit analysis is really for child welfare and for substance abuse treatment, and for this intersection, this field and this discipline and the methods to do this are really in their infancy. And so having said that, we're learning how to do this. And to just talk about for a moment, I'm going to provide an example of how cost analysis was really important, but I'm going to get to some other things first here. So in terms of pre-test and post-test, Using standardized instruments that are validated to investigate differences is really important. When looking at placement and stability, knowing critical elements such as time to reunification, the rate of reunification, the placement stability, length of time in care, length of time between a child going into foster care and the start date of when a parent actually was able to receive and initiate the evidence-based intervention. All of these are really administrative data elements that you can gather, and some that already exist through data sources. And so that pre-test, post-test, and that placement stability are really, really important. And again, your stakeholder outcomes. In terms of cost study, so I'm looping back to that now. What can we learn about the cost benefit ratio of the intervention and the program? And this tells us if the program is sustainable or not. And I will just share with you all that in two different implementations that actually three implementations that I've been involved with, we were able to conduct cost analyses. And I can tell you all that they have proven to be one of the most important sustainability tools that the regional partnership had. And this really is because services for these families are oftentimes not prioritized, or winds of change can happen. And what was once a priority in perhaps some system is now becoming a priority, or has been devalued in another system, or things just change. And what I have found is that having a cost analysis that showed that the programs were indeed cost effective really saved the sustainability of the program after federal funding was over. And so we were able to say that, you know, we saved this many days in foster care, and at a monetized rate, this savings across this number of children meant a savings offset of this. And so we were really able, as crude as the field is today, to still be able to talk about costs and to still be able to begin to look at some cost benefit as well. And so it's just really important over time to be able to say what we're doing is not only an evidence-based intervention, but it's also an intervention that represents a wise use of the state's money, or the county's money, or the judiciary's money. And so I really can't emphasize enough how important I believe that doing a cost benefit analysis is for these projects. It wasn't always pretty, and we didn't always do it as well as we would have liked, because we learned later on that there were other data elements that we would have loved to capture. But that's how the field advances, is we learn these things as we do them. And we've created a learning culture around this that is really beneficial. So I believe that project example number 7 is the one that I just described to you all. So I believe that it's really important to have that. And, looking at your program objectives, and if it aligns with the comprehensive needs of these families, substance use disorder recovery, children's emotional, developmental, and well-being needs, and family stability. These are all really important. When you developed your program and you created a logic model, you put some things over on the far right side of your logic model that were the goals that you hoped to achieve, and then some things that happened along the way. And for every box that you have there, we should be able to open up that box and look at the data elements inside that are going to be able to allow you to speak to that in the short term and in the long term. So kind of just my concluding thoughts and considerations, and knowing that we're going to be able to address some questions directly on Thursday. And so questions will be submitted, and then I believe that Dr. Young and I will take questions from those submitted. And what I believe is happening is that the evidence-based movement really is just an international experiment on how to make better use of research in typical service settings, and to produce these greater benefits to some of the most vulnerable families the public service system interacts with, and some of the most complex families whose needs are diverse yet individualized. And so it's just really important. So data-driven in all phases, from planning to outcomes evaluation, looking at the quality of your data versus the quantity of your data, use data to inform your processes. And I also want to add that it's really important that if something doesn't work, you know that too. So it's part of all of our professional commitment to practice in a way that we know works. And so if you find that something doesn't work, that is a really important finding, and should not be discounted or hidden in any way. So looking at, like, what is your program evaluation goal, or what are the multiple goals to move science? Absolutely, that's what we're trying to do. To improve practice, you bet. We're trying to, most of us who are in this work, it's because of our passion and commitment to this population, and we want to improve practice, but we also want to be able to tell other people what we have found, so that we can advance knowledge in the field. And really thinking about when your randomization takes place, or how you create a comparison group, is also very important and has been really critical. The standards for rigor are changing constantly, and it's happened to us that from the time that we conceptualized a program to when the final outcomes evaluation was due, the standards changed. So I want to say that you need an evaluator with you every step of the way. And thank you for being interested in programming evaluation and in data. I believe it is the key to effectiveness and sustainability. And I want to just thank you all for being interested in it. I also want to give a quick shout out to Kylie Liming, who's on the call, who helped me create this PowerPoint, and she has been the evaluation manager on 2 of the projects. And all of these projects were federally funded projects, but the perspectives here are really my own and don't represent that of the funder. So I believe we're right at 12:59 Central Time. So thank you for joining and attending, and we hope that you will see you as a participant on Thursday with questions that we can address.
Great. Thank you so much, Jody. Now everyone knows the wealth of your knowledge. Thank you again, and thank you for everyone who's participating today. Bye now.
Bye-bye. Thanks so much, everyone.